in listen-only mode.
Good afternoon, and thank you for joining the RLS Foundation's webinar titled Opiates and RLS. My name is Zibby Crawford, and I'm the Communications and Marketing Coordinator at the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Early will answer as many questions as time allows after his presentation. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the member.
I just lost.
If you are not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to the website at www.rls.org. Our speaker today is Dr. Christopher Early. Dr. Early received his medical degree as well as a PhD in pharmacology from the University College in Galway, Ireland. He completed his residency in internal medicine at Baylor Medical College and then went to the University of Virginia in Charlottesville to complete his residency in neurology. Dr. Early spent a year at the National Institutes of Health as a fellow in the neurobiology unit before joining the faculty at Johns Hopkins in 1991. Dr. Early's research and clinical interests are devoted to sleep medicine with a special interest in RLS. His current research is focused on understanding the pathophysiology of RLS and further revealing the value of various treatments in this syndrome. Dr. Early is a co-director of the Johns Hopkins Center for RLS Quality Care Center in Baltimore, Maryland, and is a member of the RLS Foundation's Scientific and Medical Advisory Board. Dr. Early, we thank you for sharing your time and your expertise with us today, and I now invite you to begin your presentation.
Thank you. To all listeners, I will be talking about the role of opiates in restless leg syndrome. And I would like to start with sort of going over what we know about the natural opiate system in your brain. So before we discovered morphine and all the other opiates, has always existed to some degree in mammals a set of chemicals or peptides which are there naturally, and they stimulate the morphine receptor, what was to turn out to be the morphine receptors, and a couple of different other types of opiate receptors. At the current time, there is at least 4 known peptides that are part of the natural opiate system. Dynorphin, as you can see in the top left, is a very complex molecule. And then the beta endorphins, you're all familiar with endorphins. Exercise increase your endorphins. That's also an equally very complex molecule. And then you get down to 2 forms of enkephalin, metenkephalin and then leuenkephalin, which are much smaller molecules but equally complex. I'd like to point out that there are chemicals in our brain that make us happy, and that includes dopamine and the endorphins. And so when we talk about the natural opiate system, we're talking about a system that's very much involved in reward, satisfaction, and many things more than just pain. We're often associate opiates with pain and pain management, but the opiate system in your brain really is evolved to be a little more complex than that, and more interactive in a large part of your thinking, your processing, particularly when it comes to reward and satisfaction. There are actually 3 different types of proteins or receptors to which these natural opiates bind to, and to which the opiates that you take, like oxycodone, codeine, also bind to. So it's very complex. I want to go over sort of in a very systematic way some of what happens when a opiate receptor gets stimulated. So those little green dots, if we look at them as representing the natural opiate or oxycodone or morphine, it's going to stimulate a receptor, which is a protein which sits on the membrane and translates that chemical into a signal. In one scenario, the signal can be very complex, affecting a various bunch of proteins called G proteins, cyclic AMP. It can feed back and then alter how calcium or potassium fluxes in and out of the cell. That same receptor then can form a different form of receptor called phosphorylation, and it can have a different set of signals. It can be taken into the cell, and in that cell it can produce a set of signals. And then the fourth is either one of those forms of the receptor can have a completely different set of signals related to other proteins. And then finally, that receptor can be sequestered back onto the membrane to start the whole process over again. I don't anticipate the average individual will fully comprehend all the aspects of this receptor interaction. The point of this picture is to demonstrate that any natural or pharmaceutically made opiate has complex interactions on several different types of opiate receptors. And that trying to understand how an opiate works on the brain is not simple. It is very complex. Certain forms of drugs like the morphine or oxycodone may have a different type of signal than the methadone or the fentanyl. We'll talk about that. So when we talk about opiates as a class of drugs, understand they're quite structurally different, and because of that different structure, they're going to have different types of reactions on this complex figure that you see here. Even though they may all reduce pain, they may do something different for other aspects of the opiate system in terms of reward, satisfaction, and in the case of restless leg syndrome, it may have differential effects on restless legs. The opiate system does not live in isolation. The opiate system is interacting with other brain systems, and particularly those that are relevant to restless leg syndrome. The dopamine system, it has direct and indirect effects on the dopamine system. Also on the glutamate system. We now appreciate that the glutamate system may be an important system in the brain that's relevant to restless leg syndrome as much as the dopamine system is. And so when we have a interaction between these systems with morphine or oxycodone affecting various different transmitters, you can see it becomes even a higher level of complexity as to what they are doing at any given time. Obviously, when you start mixing medications, giving a dopaminergic drug or giving an opiate, you may be working on similar systems or the same systems, but again, the interaction may be somewhat unpredictable given the complexity of the situation. It's important to point out that work by Art Walters and some of his colleagues looked at autopsy brains in patients with restless legs and control patients, and they looked at the area of the brain called the thalamus. The thalamus is a area of the brain which is very much involved in receiving sensory information and then taking that sensory information and sending it up to your higher cortex. As restless legs is a sensation, it's is to be expected that the thalamus might be involved in how information is received and transmitted out of the system. So they looked at the opiate system, the endorphin, beta endorphin and metenkephalin, and how those two natural opiate peptides may modify or be found in the thalamus. And what they did find is that in RLS patients, the beta endorphin in the thalamus was lower, and the metenkephalin was also lower in patients with restless leg syndrome. The data supports the concept that restless leg syndrome is associated with an imbalance in the natural opiate system. In the same way that we talk about an imbalance in the dopamine system, the truth is we should be also talking about restless legs as a potential underlying problem with the natural opiate system. So let's look at the opiates that are used clinically and sort of get some idea of what they look like, what they do, and sort of their interaction with or comparison with morphine. There is, to the right of your screen, a series of molecules, 8 of them. The base molecule is morphine. As you can see, you have oxycodone at the far bottom left, and then hydrocodone, and then codeine. They all look very much alike. These are all derived from the morphine alkaloid. And so codeine, hydrocodone, oxycodone, oxymorphone, hydromorphone, they all are based upon some change in the morphine molecule. So these are morphine derivatives. And because of that, they tend to have a similar action on the natural opiate receptors. In this case, morphine and its derivatives primarily stimulate what's called the mu receptor. As I mentioned before, there's the mu, delta, and kappa receptor. The morphine tends to stimulate primarily the mu receptor. Oxycodone, there's some data suggests it's again, it may have some effects on the kappa receptor. There's some indications that the hydromorphone might have some effects more in delta. So there are some subtle differences in the chemical structure of these derivatives that suggest that even though they may be all potent stimulants on the mu receptors, they may be slightly different action on the delta or kappa receptor, somewhat different enough from morphine to make them potentially of value if, for example, the morphine doesn't work, or if the oxycodone doesn't work. The hydromorphone might work in a scenario like treating restless leg syndrome. The next is the structure of methadone. Please note that the methadone has no resemblance at all to the morphine molecule. It is a fully synthetic molecule. The Germans designed this molecule back in 1937, so it's a very old molecule. It has action, it stimulates both the mu receptor, delta receptor, and the kappa opiate receptor. So you can see it has a broad effects on all 3 different receptors that morphine doesn't have. It is what is referred to as a non-competitive inhibitor of the glutamate, NMDA glutamate receptor. So that's something unique. By non-competitive, we mean it doesn't actually kick the glutamate out of the receptor. It basically binds to the side port and prevents the glutamate from having an action on its receptor. The time it takes, when you take this drug, the time it takes for the drug to reach its peak dose effect is about 3 or 4 hours. The half-life is that how long the drug, half of the drug stays in your system is about anywhere from 10 to 60 hours. But on average, it has a very long half-life, about 16 to 24 hours. The standard dosing regimen for methadone in restless leg syndrome is 2.5 milligrams, which is half of the smallest tablets, which is a 5 milligram tablet, to as much as 20 milligrams a day. That's sort of what 85 to 90% of patients will need for managing the restless leg symptoms. It is worth noting that methadone in animal models of addiction and chronic pain show less tolerance develops to methadone than it does to morphine for pain. That methadone can desensitize the mu receptors. One of the concepts in drug dependency with morphine is that the morphine molecule binds to the mu receptor and won't let it go. It overstimulates it, so it eventually desensitizes the receptor, which leads to tolerance and potential dependency. And so one of the unique properties of methadone is it binds to the receptor, but it doesn't avidly bind. It actually allows the receptor to regain some of its sensitivity back and act normally. It will also block what's called morphine-induced sensitivity. What we know when we chronically use morphine is that even though initially it may reduce pain, but sometimes it may lead to a hypersensitivity, such that pain actually gets worse. And methadone can block this effect without, thus, again, preventing the morphine receptor from becoming overly sensitive. Again, if you look at the dose equivalency between methadone and oxycodone. Oxycodone is Percocet. It's what most doctors hand out for pain. So 5 milligrams of methadone equals 5 milligrams of oxycodone if we're managing pain. If we're managing restless-leg syndrome, 5 milligrams of methadone equals 20 milligrams of oxycodone. So methadone has a higher selectivity for whatever mechanism is driving restless legs compared to whatever mechanism is driving pain. So it does have some unique properties to it that seem to be special for restless legs. This basically is a chart showing you the affinity, the degree to which methadone will bind to this glutamate receptor, this NMDA receptor. What you can see, it avidly binds to this receptor, both in the brain and in the spinal cord. Now compare this to morphine. You can see that morphine has no binding properties whatsoever to this receptor. Again, making methadone unique among the opiates, and that it's not a morphine derivative, and it binds to this receptor, which we believe is relevant to treating restless leg syndrome. And therefore, morphine and its derivatives do not do this. Another opiate is fentanyl, and as you can see, compared to morphine, is again quite unique. It doesn't have any chemical properties that look anything like the morphine molecule. So this is again a fully synthetic opiate. It has a very potent effect on the mu receptor, like morphine itself and like methadone. It has some mild effects also on the kappa receptor as well. It's mild. Actually, methadone has a more potent effect on the kappa opioid receptors than the fentanyl, but at least has some mild effects on it, which morphine does not. It takes about 6 to 12 hours for the drug to reach an even steady state in your blood. It is basically provided as a patch. So fentanyl is a patch that you place on your skin, and the patch will last anywhere from 48 to 72 hours. The doses that are commonly used for restless leg syndrome vary from about 12 microgram per hour patch, 25 microgram, up to 50 microgram per hour patch. There's less nausea and itching associated with it compared to morphine. There is, however, more respiratory depression, so more problems with breathing issues or feeling short of breath compared to morphine. The next opiate that I want to talk about is buprenorphine. It is a very old drug. In fact, it was given FDA approval based upon an orphan drug category. As you can see, it is somewhat like morphine, but actually it is even more complex than morphine. This chemical is actually derived from thiophane. Thiophane is another plant alkaloid, like morphine is a plant. It's just derived from a different plant. It's semi-synthetic, that there's a slight modification of the thiophane to produce the buprenorphine. Buprenorphine has what is called a mixed agonist-antagonist property. That is, it stimulates some opiate receptors. At the same time, it may actually block other opiate receptors. So it has also what's called partial mu receptor agonist. This is a pharmacological term, meaning that the chemical will bind to the mu receptor, but not overstimulate it. In fact, if it gets too stimulated, it will actually stop stimulating the receptor. So it has the capabilities of stimulating the mu receptor, providing pain relief and other factors that you would get with morphine, but it tends not to overstimulate or flog the receptor to the point of tolerance. It has a full kappa and delta receptor antagonism. So unlike methadone, which stimulates the kappa and delta receptor, buprenorphine actually blocks these receptors or keeps them from being stimulated by your natural opiates in your brain. This drug is given sublingually. You put it as a tablet or a film into the under the tongue or into the side of your cheek, and you let it dissolve. The half-life of this drug is approximately 36 hours, anywhere from 24 to 60 hours. There is a form of a patch. It's a 7-day patch, which is formally approved by the FDA for chronic pain. The problem I have with the patch is most people can't keep the patch on for more than 3 days, because if you sweat it or have to take a shower, the patch will usually finally come loose after about 3 days. And the insurance company doesn't like the fact that you have to buy a patch every 3 days. So it tends not to be a practical application of this drug. The sublingual or the sublingual film or tablet are the most practical. Again, from the point of view of treating restless leg syndrome as opposed to chronic pain, the doses that are often used is 0.5 milligrams, which is, they have a 2 milligram pill or 2 milligram film. I usually give the film because the film you can cut and slice into a quarter and use it. And then up to as much as 6 milligrams per day. On average, it's approximately 2 to 3 milligrams per day is what I end up needing for most of my patients if I have them on the buprenorphine for restless legs. It has been shown to have antidepressant effects in clinical trials. There's less respiratory depression than morphine, and essentially less neonatal absence syndrome. So when women who are pregnant go on opiates, there is some respiratory depression that may appear in the neonate when they're born. It is less of a problem with methadone than the other morphine derivatives. But it's significantly less for the buprenorphine than it is for the methadone. So it's becoming more commonly used among drug dependency in women who become pregnant to prevent this the problem of this neonatal absence syndrome. I just want to show you some comparison of safety profile of buprenorphine versus the other opiates. There's methadone in the list, and fentanyl above it, hydromorphone, oxymorphone, and then the buprenorphine. As you can see across the bottom, that there's less problems with constipation with the buprenorphine, less sedation with the buprenorphine, less respiratory problems, less tolerance with the buprenorphine. Limited, I can't say zero dependency, but it appears to be very limited problems with addiction and dependency. And then there is the issue of hyperalgesia. When used with chronic pain, morphine and its derivatives tend to hypersensitize the mu receptor and often make the pain even worse. So it becomes sort of hyperalgesic. The buprenorphine almost seems to block that effect. The next chemical is pentazocine. Not a very commonly used drug. I use it a lot because I actually think it has some value more for restless legs than it does for pain. As you can see, it has somewhat of a look of the morphine molecule, but not quite. So it's a semi-synthetic. It's called a benzomorphine. It's sort of derived from the alkaloid molecule, but it's not fully structurally like morphine. This drug is unique among the opiates in that it has solely stimulates the kappa opiate receptor. It has no effect on delta, has no effect on mu receptors. It's strictly a kappa opiate receptor stimulant. Because of that, it has less problems with constipation because most of the side effects, sedation and constipation, bladder retention, all those factors tend to be related to the opiate's effects on mu receptors, not related to the kappa receptor stimulation. No mu or delta, as I mentioned. It does have some effects on this NMDA receptor, similar to methadone. It actually has it blocks the glutamate directly on the receptor, which is somewhat different than what the methadone does. But again, it does have some antagonist effect, which might be why this drug is relevant to restless legs per se, more so than for pain. Again, it takes about an hour for this drug to reach an even peak in your blood. Its half-life is about 4 to 6 hours, so it's a relatively short half-life. So if you take it, you have to take it sort of every 6 hours in order to keep the levels up. The average dose, it comes as a 50 milligram pill. The average dose on a daily basis would be 50 to 100 milligrams as a single dose. So if you had evening and bedtime symptoms, you'd probably have to take 1 or 2 pills in the evening and then 1 or 2 pills at bedtime. The last one is tramadol. As you can see, structurally, it has no structural similarity to methadone, to morphine at all. It's again a synthetic. Though it is referred to as an opiate, there are some other properties. It appears to block the uptake of serotonin and noradrenaline, blocks their transporters. This mechanism is similar to the mechanism that is behind the use of drugs like nortriptyline or amitriptyline, which are the old tricyclic antidepressants, which are often used for pain, for facial pain or neuropathic pain, because of their effect on blocking the uptake of these two chemicals, serotonin and noradrenaline. The exact mechanism of how these actually play in the pain mechanisms, in truth, we really don't know, but it seems to be a relevant property that tramadol has that suggests that part of its pain relieving property is through this process, similar to nortriptyline or amitriptyline. It does bind to the mu receptors like morphine, but its affinity for that receptor is really very poor, and so it's 10 times less potent than codeine binding to this receptor. It's 60 times less potent than propoxyphene, which is again a mild opiate. So it's 60 times less potent in binding to that receptor than a mild opiate, and it's 66,000 times less potent than morphine itself. So even though it does bind to the mu opioid receptor, it's not clear that its binding is all that relevant to what it actually does from a pain management point of view. It is classified as an opiate, but it's an awful weak opiate if it really is how it operates. If you take the medication, it takes about an hour and a half for it to reach a nice even peak in the blood. Its half-life is 4 to 6 hours, so it's relatively short. Unique to the opiates, again, if we wish to refer to it as an opiate, which is how it is classified, unique to the opiates, tramadol does cause augmentation, similar to the dopamine agents. The other opiates do not. So let's talk about opiates and pain and restless legs and the nature of it. We all understand opiates and a lot of interaction of opiates on the nervous system and issues of tolerance and addiction we associate with opiates being used for chronic pain. Is restless legs chronic pain? If opiates work for chronic pain, should opiates work for restless legs? We know they work, but say 20 years ago, 30 years ago, should someone have figured it out that it should work for restless legs? So is restless legs a pain? Is restless legs a pain syndrome? If you go to the medical dictionary for the definition of pain, it states, and I've underlined the important words, it states a state of emotional lack of well-being or emotional uneasiness that ranges from mild to unbearable agony, is a consequence of some derangement of a physical function as through a disease that produces a reaction of wanting to avoid, escape, or destroy the causative factor and its effects. That more or less describes pretty bad restless legs. So many of you may not consider it painful, very uncomfortable, but it falls into the category of a pain syndrome. And this is the point that Ekbom tried to make back in his larger thesis paper in 1964. Quote, some patients speak of pain, but on careful questioning, they generally admit that it is a matter of discomfort rather than actual pain. It's important to point out that restless legs does not fit the classic pain category. Restless legs is associated with both a sensory and a motor component, the periodic leg movements, that both respond to opiates. Pain has no motor component. Chronic pain has underlying pathology that does not appear related to RLS, no more than the pathology of Parkinson's disease relates to RLS. So when we talk about chronic pain and restless legs, they represent probably two different pathological conditions, although they may both fall under the rubric of a pain syndrome. So Ekbom did have some statements about opiates. Professor Willis in his 1868, I think, treatise did report that a patient of his responded very well to opium at the time. So that was the first report of opiates use in and what was probably restless leg syndrome. Ekbom was probably the next individual to bring out the value of opiates in managing restless leg syndrome. As the quote states, I have seen certain patients who have taken a narcotic orally every night for years. Some of them did not need to increase the dose. In a few cases, true narcomania, although of moderate degree, finally appeared with gradual increasing doses. Whether that was tolerance, whether that was just the RLS worsening, we don't know. But obviously, in some cases, there was need for more opiate. In the same paragraph, he reports that the use of narcotics should be avoided. And he goes on, et cetera, and at the very end of that paragraph, he concludes, I nevertheless believe that it may sometimes be justified to give codeine or opiates in desperate cases. So let's look at the studies of opiates in restless leg syndrome. There have been 5 open label. That means they were not blinded, they were not randomized. The patient knew what they were getting, the doctor knew what he was giving. So there are 5 open label studies. Most of the studies report decreasing leg movements and increasing sleep efficiency, as well as improvements in symptoms. There have been 3 randomized double-blind clinical trials of the opiates, and we'll talk about Trent Walter's most recent study in 2013, which appeared in The Lancet. I'll talk about that a little later in the presentation. And there are 3 longitudinal case series, and we will talk about Silver et al., which was the work we did here at Hopkins. So the longitudinal study by Silver and our group is a 10-year longitudinal assessment of dopamine agonists and methadone. Basically, we keep a database, or all consecutive patients that come into our clinics get entered into the database. And so we had all patients seen between March 1st of 1997 and March 1st of 2007. So 10 years of data. We've reviewed duration, the dose of drugs used, the reasons for discontinuing them. We looked at ropinirole, which we had 74 cases, pergolide, we had 77 cases, pramipexole, 164 cases, and methadone, we had 77 cases. This survival plot basically shows you the degree to which people continued to use the medication. As the lines drop down, it indicates that more and more people dropped out. So it's referred to as survival curve. We published this in the paper. And essentially, if you look at the 6-month point, just about everyone, irrespective of the medication that they were on, had dropped out. About 12%, 12 or 13% of patients had discontinued the medications for various different side effects. The doping agents had nausea, vomiting, nasal congestion. The methadone had problems with sedation, constipation, things like that. But once we get beyond the 6-month point, we see that Requip had a tremendous drop-off, most of it related to augmentation. You see pergolide within the 10-year period had come to 0. And then Mirapex at the 10-year point still had some people still on it. So Mirapex at least appeared to be less likely to produce side effects requiring patients to discontinue the medication. For 90+% of people, the reason for discontinuing the medication, Requip, pergolide, or Mirapex, after 6 months was augmentation. For patients on methadone, there was virtually no patient who dropped out over that period of time. The overall difference between the average dose of methadone at 6 months versus the average dose at the end of the evaluation was only 10%. So very little indication of tolerance to the methadone over that period of time. So let's talk about Dr. Trent Walter et al.'s study. This was a study of extended release oxycodone versus placebo in the double-blind randomized trial. So this was 12 weeks. Patients didn't know what medications they were getting. the investigators didn't know what medications they were getting, and there was a 40-week open label trial that after the first 12 weeks of the study, the blind was open, and then everyone was allowed to go on the opiates for the next 40 weeks. So we can look at how the opiates worked over the next 40 weeks in terms of the symptom, maintaining, sustaining improvements in symptoms. The inclusion criteria were fairly standard for most clinical trials of restless leg syndrome, except for patients had to fail other treatments. One of the reasons for failures is they developed augmentation on opiates, or augmentation on dopamine agents. They were then allowed to come into this trial. So this was oxycodone extended release versus placebo, reasonably large study. The medication was given twice a day. That was up to the physician to decide how they were going to give it twice a day. There was something close to bedtime or evening, and there was something in the early evening or early afternoon for most of the cases, but twice a day dosing. Patients had to be off all other RLS medications for at least 7 days, and most of those were on dopamine agents. They started with 5 milligrams twice a day and then titrated up. The maximum dose was 40 milligrams twice a day. They had to achieve this dose in the first 6 weeks of the trial, and then for the last 6 weeks of the trial, they were on a steady state level. The primary outcome of this trial was change from baseline in the International RLS Severity Scale, which is the standard outcome measure for all of the RLS trials. Basically, it's a measure of restless leg severity. And so the oxycodone group showed greater improvements in the RLS scale at 12 weeks. It showed greater improvements in other scores of severity and also scores of sleep quality. They had a higher incidence of side effects common to opiates. So patients that are in the oxycodone group had higher incidence of sedation, constipation, etc. Not surprising. The sustained benefits were, the benefits of the opiates were sustained over the 52-week period. There was no serious withdrawal symptoms at the end of the trial, and there was no augmentation after 1 year. So I just want to show you the hard data. In these are the restless leg scores. You can score up to as much as 40 points on the RLS severity scale. The average person started at a score of about 27, 28. They had to come off medications. They had a worsening of their symptoms when they come off medications, and then they continued to show. The red line is the oxycodone. The blue line is the placebo. Patients were probably augmented severely on the dopamine agents. And so when they came off the dopamine agents after 7 days, their symptoms worse, as many of you who may have come off of a dopamine agent know. And then over time, the symptoms improve. So part of the placebo effect is simply getting off of the dopamine agonist. In fact, if you want to look at it in a positive way, coming off of the dopamine agonist for placebo was probably more of a benefit than anything. But clearly, being on the oxycodone was even more valuable to them in maintaining very low scores throughout the 12-week period. After the 12-week period, they were taken off of the medication. In this case, placebo was no medication, but the oxycodone was. The symptoms worsened off of the medication, and they put everyone back on the medications over the 40-week period. So as you can see, the oxycodone had the improvements in both the blue group and in the red group, straight on through. No change whatsoever over the 40-week period, indicating at least for this duration of time, which is quite significant, there was sustained benefits in the use of the oxycodone. If you compare this data to the study done and presented in the New England Journal of Medicine, where they looked at Mirapex versus Lyrica over a 1-year period, if you compare it, you can see that over the 1-year period, patients in the Mirapex group started doing worse and worse. In fact, if you compare it, you can actually see that Mirapex would probably come out somewhere around here. So this is important. I think one of the most important findings, because I think most of us in practice believe that the opiates work, but no one until this trial had actually done a randomized double-blind trial to compare the short and long-term efficacy of opiates for restless leg syndrome. So let's look at the recommendations. Many patients will speak to their family doctors, and their doctors will be surprised that opiates are used for restless leg syndrome. Well, it's written in black and white. I recommend everyone get a copy of this and give it to your family doctor. And this is the revised consensus statement on the management of restless leg syndrome, which appeared in the Mayo Clinic proceedings in 2013. There was talk about opiates and refractory RLS. Refractory RLS is restless leg syndrome unresponsive to monotherapy with tolerable doses of first-line agents, i.e., you've tried the Horizon, you've tried the Lyrica, you've tried the dopamine agents, but due to a reduction in efficacy, augmentation, or side effects, the drug wasn't working. So that's refractory restless leg syndrome. Under those conditions, we recommend the use of opiates. Well, first, you always should check your iron levels, make sure the iron hasn't changed. That's a reason why your restless legs is worsening and the drug isn't working or doesn't appear to work. The other is making sure they don't have other factors, sleep loss, use of SSRIs. But in the end, if none of those appear to be the case, we recommend that an opiate could be added, but more importantly, considering getting off the medication and using opiates as a monotherapy is a recommendation. So it's part of the recommendations for managing restless leg syndrome. So let's talk about treatment plan. Pretty simple. Opiate monotherapy. If you go on one agent and it doesn't appear to work, you should always try another. As I just tried to show you, there's so much diversity within the opiate system, opiate drugs. Even among the morphine derivatives, there's subtle changes, subtle differences between oxycodone and morphine and hydrocodone that may be relevant to an individual. They get metabolized different. So if you go on oxycodone and it doesn't work, it doesn't mean that codeine or hydrocodone won't work. So if one fails, try another. Dual therapy. Choose from different classes. Sometimes the oxycodone or methadone will work very well. It will cover maybe 70 or 80% of their symptoms. Going higher doesn't seem to make a difference. Going from methadone and adding, say, something from the morphine derivative class, like oxycodone or morphine itself, may be additive because they're working, again, differentially. Consider opiates plus an alpha-2 delta agent. Again, you're coming out of different classes, but they tend to be synergistic. That even though, say, gabapentin or Lyrica didn't work as well, combining it with opiates might allow you to get away with less opiates and find that the alpha-2 delta agents actually are effective in this scenario. Opiates plus dopamine agonists. The big question is, if I use an opiate in combination with an agonist to start with, can I prevent augmentation? We don't know. Clearly, you're more likely to use less agonist, less dopamine agonist, because obviously the opiate will be covering some of your symptoms, so you'll need less of the dopamine agonist. And it is clear that less dopamine agonist used, the less likely augmentation is going to develop, or at least much delay in the development of augmentation. Whether using the opiate can somehow prevent it, we don't know. Side effects of the opiates are fairly standard. The sedation, constipation, occasionally nausea and vomiting, depression, insomnia. I don't have here itching. I should remind you, itching. About 10-15% of patients is not an uncommon side effect. It may worsen obstructive sleep apnea. It may cause some central sleep apnea. And drug dependency. I don't want to whitewash the concept that there's always the risk of drug dependency with any opiate at any dose. So opiate use, restless legs, and drug dependency. Opiate use is associated with increased risk of drug dependency under any condition. Chronic pain has an underlying pathology that may enhance the risk of drug dependency. So when opiates are used with chronic pain syndromes, there's probably a greater risk than when they're not used. So the point is, most of what we understand about drug dependency tolerance is derived from chronic pain models. And as I mentioned before, It's not clear that we can actually extract from that information something that's useful for RLS. RLS is not biologically in the same class as chronic pain. Therefore, how well can we extrapolate from what we see with opiates and chronic pain to the use of opiates in restless leg syndrome? As a case in point, use of levodopa and dopamine agonists in Parkinson's disease never predicted the effects that are seen with these drugs when used in restless leg syndrome, which is the augmentation and the severe drug dependency associated with the dopamine agonists. That's the end of my discussion, or presentation, sorry.
All right, thank you. Here are some questions that were submitted before with registration. I am taking oxycodone 4 to 5 milligram tabs as needed. It's working great. My doctor is worried that he may be questioned about this prescription. Why is this so?
Well, I think most of us are aware through the media in one manner or form there has been a major social concern about opiates in the last 2 years. A lot of states are passing new laws about controlling opiates. And so I think at this stage many physicians are just scared that their use of the opiate is somehow going to get them having the DEA knock on their door and taken away. There is clear indications that opiates work. There is clear indications that opiates are part of the recommendation for medical management of restless leg syndrome. And the guidelines clearly indicate that opiates are appropriately used where medically indicated. The biggest issue with the DEA and the FDA is when opiates are used for non-medical reasons. Opiates for restless legs is a medical reason and appropriate. I have no way of quelling the fears of any physician out there. They are right to be very concerned because it's a very hostile environment out there about opiate use. We talk more about the abuse of opiates rather than the successful benefits that it has given to people with chronic pain and restless legs, but that's the spectrum of the discussion at this point in time.
I have essential tremor and suspect RLS. Has comorbidity been observed, and are opiates an appropriate treatment method of treatment?
Opiates don't work opiates are not indicated and don't work for essential tremor. There has been no real substantial data to support the idea that essential tremor and restless legs have underlying similar pathologies. Both are very common. In fact, essential tremor or familiar tremor is probably more common than RLS. So by chance alone, you could have both.
What are the guidelines for stopping an opiate once started?
Well, it depends whether you're talking about restless legs or you're talking about chronic pain. And whether or not the patient with restless legs also has chronic pain and the opiates are being used for both pain management and for restless legs. The guidelines straight up for the simple idiopathic RLS is basically a slow taper. There's no specific guidelines beyond slowly tapering down and coming off. It's a pragmatic one. That is, if you're on high doses, you're going to have to take your time and come down. If it's on relatively low doses, then discontinuing the opiates. In my general practice, I've not found the same degree of problems of rebound restless legs or horrendous resurgence of restless leg syndrome symptoms when coming off the opiates compared to coming off a Requip or Mirapax. So it is not of the same ilk as one might have experienced had they had to come off of one of the dopamine agonists.
Okay. I know opiates are addictive. What are some signs of addiction? Can one of these symptoms be frequent tiredness or headaches?
No, addiction really is a psychological issue. What the tiredness and headaches and things is really about side effects, not addiction. Addiction is essentially it's true for any, whether it's cigarettes, alcohol, cocaine, heroin, opiates, Requip, Mirapex. It's the same issue that you have this craving or need to take this drug, and you'll go to any extreme to do inappropriate things. Go on the streets and buy it. Go to multiple different doctors and buy it. How does one differentiate need for medication versus addiction? And that is a little tougher question. If you are on opiates for your restless legs syndrome, then you probably have had bad symptoms, have gone through the whole process of the various different other medications, and the medication's taking care of your legs. Obviously, you don't want to come off of this medication because your restless legs would come back. Therefore, you need it to keep your symptoms at bay. How do you translate that in? How does one translate that information into addiction? I guess if suddenly you're needing more, well, is the RLS getting worse? Or are you getting tolerance? Is this drug seeking? Is this addiction? It's a very hard line. I mean, when you see the worst case scenarios where patients are on the street buying black market opiates, or going to 3 or 4 doctors and dropping into ERs and picking up opiates. I mean, when you see it that way, it obviously becomes that it's addiction. When you see the fact that the patient is just needing the medication in order to keep their restless legs from getting worse, that's just needing it. There's a big gray zone in between that, trying to decide, is this need, is this addiction? So it's not that easy, even though the literature talks about addiction, things like that. I think from a real social medicine point of view, differentiating the person's wish not to return to suffering versus the person's inappropriate need to satiate this drive to have more is hard to discriminate.
How long is it feasible to be maintained on methadone? I was placed on the drug 6 years ago. It has been effective with Nupro.
No, I mean, I have no limitations. I don't have any limitation on any of the RLS medications, so long as they're working, so long as you're not needing more and more, so long as you're not having side effects. I mean, our 10-year data was, 8 years. We finished it 8 years ago. I have patients on methadone for 15, 16, 17 years at the same dose and same time. So, I mean, if it stops working, it stops working, and then you stop and go on to another medication. That's true for all of the RLS medications.
What is the best opiate for RLS?
If you're dealing with restless leg syndrome only, as opposed to other pain-related syndromes, so some patients I have neuropathies or arthritis, and so there's a coexisting pain issue. The morphine derivatives are probably far superior for pain than, say, methadone. Methadone is probably far more superior for restless legs than it is for pain. After these many years using opiates for restless legs, I have a great respect for the value of methadone above all the other opiates for managing restless legs, and I think in part because it is seems to show somewhat a unique pharmacological effect with the glutamate system, and clinically it is differentiating itself from its pain component because it's actually more effective for restless legs at lower doses than the morphine derivatives. At the same time, as I mentioned, if you look at methadone and oxycodone from a pain management point, they seem to be same. They seem to be working. 5 milligrams one equals 5 milligrams the other. When you actually look at it for restless legs, it's better for restless legs at a lower dose, which means lower side effects, lower problems. And also, the value of methadone and the reason it has been used for drug dependency, heroin dependency, things like that, is because of its issues of less tolerance, of desensitizing the morphine receptors and allowing people to get off of opiates. So it has that property of at least potentially being less likely to produce tolerance or dependency than the morphine. It's not zero, but it's just less than what you're likely to get with the morphine derivatives.
Is there a daily maximum dose that should not be exceeded for each opiate drug used in RLS treatment?
I have my general rule of thumb, and those are on the slides. Will I go above those? I will. I have many complex cases, and so they're not always simply about restless legs. When I deal with chronic pain conditions, I will tend to have to use pain level doses. So methadone for chronic pain is 50 to 100 milligrams a day, as opposed to 5 to 20 for restless legs. And so if I have to deal with a chronic pain syndrome, I will sometimes work to help with the pain as well as the restless leg symptoms. And the restless leg, if you're dealing with pain, and a combination of pain and restless legs, the restless legs will always come under control well before you get the pain under control. But sometimes it remains a continuous aggravate of the situation. And until you get the pain under reasonably better control, it won't stop aggravating the restless legs. So sometimes you really have to go to the higher doses. But in general, the doses that I outlined in the slides are the dose ranges that are going to be used in essentially 90% of patients.
Suboxone is a controlled substance. How is this drug similar and different from opiates?
Suboxone is the buprenorphine. That's the one I talked about, the buprenorphine. As I mentioned, it is a plant derived from a plant alkaloid thibane, which has similar properties to the morphine alkaloid. It has properties, as I mentioned, that make it, I think, a lot safer. Lower problems with side effects, lower problems with dependency. I have used the buprenorphine as my sort of rescue drug, and so when I've moved to the opiates and have used the methadone, and patients are having side effects with the methadone, I'll try them on the buprenorphine. Usually I can get away with less problems with things like depression. Some of the sedation properties, as you see with methadone, seem to be less likely to occur with the buprenorphine. So I use it in that scenario. It has, the only real restriction is that it's insurance restrictions. Some insurance companies just won't pay for it, which is a problem, unfortunately. So,
is methadone a 24-hour prescription, and would it prevent someone from being able to drive?
Being able to prevent you from drive, that's true for any drug that sedates you. Always has the potential to cause problems with driving. That's true with gabapentin, Lyrica, which can cause sedation. When you use a dopamine agonist at high doses, it can cause narcolepsy-like syndrome. So any drug that has the potential to sedate, you always have to be concerned about sedation. That having been said, there are many patients on opiates at very high doses who don't have any sedation. There are people at low doses that get a bit of sedation. It's a personal experience. It's a side effect issue. Methadone's half-life, clinically speaking, is good for about 12 to 16 hours. If I have to cover symptoms throughout the whole day, I tend to split the dose. I don't think the methadone will quite last the 24 hours to cover 24/7 symptoms of restless legs.
Okay, we just have about a minute left. I'm going to ask the last question. Can you share with the audience the current RLS-related research project you are working on?
Well, I have several. We are currently looking at iron, again, IV iron infusions. There's been one study out there. We are planning to get another study going in the next, hopefully, month. We have our IRB done. We're waiting for the company to finally sign the contract. And I am doing some work in the area of what's called epigenetics. We are looking at the genes and seeing if there's any modifications in the genes that might be very specific for Restless-Legs syndrome. Specifically, we try to look at the genes in your lymphocytes, so something that we can easily collect from everybody and see if there's any specific signature in your genes with these that might identify Restless-Legs syndrome. When we're looking at populations of patients who are iron deficient, seeing if the iron deficiency creates changes in the genes that might permanently affect people's ability or risk of developing RLS in the future. Those are the two big ones we're doing anyway.
Excellent. Thank you so much, Dr. Early, for your time, and for to our audience for your attention and interest in RLS Foundation. Please go to our website to look at various different webinars that we've conducted in the past. We have another one coming up in March on children and RLS. Thank you, Dr. Early, and thank you, everyone, for attending.
Thank you. Bye.